what we've done is we've already placed in the guide wires for L1, L2, L3, L4. So we're going to do L5, which is pretty, L5 will pretty much represent how you normally put in the screws at the lumbar levels. Can you guys see the x-ray there?
Yes.
So interestingly, this patient has a transitional vertebra with a sacralized L5 vertebra. So if you can see the picture here, so go ahead and take an x-ray there. I am at the 9 o'clock position on the left pedicle of L5, so I'm going to make an incision here. So what I'm going to do is I'm going to try to match this angle here of this beam. And then can I see this here? So essentially the tip of this, and I don't know if you guys can see these lines that I've already drawn out, but essentially, just like what I talked about in my talk, I drew a midline, one midline, mid-sagittal, and then I have two parasagittal, one out here, and then one out here. And these represent sort of the guide wires that I put just outside of the lateral border of the pedicle at every single level. And as you know, in the thoracic spine and the upper lumbar spine, it's almost in the sagittal plane. But as you go from cranial to caudal, it starts becoming more coronal. So essentially, typically in the thoracic spine, I'll draw this line just right outside, maybe just like a few millimeters just lateral to the lateral border of the pedicle. And then as we go out to L5 and S1, it becomes more like a centimeter or two because of the fact that you have to take much more of an outside to inside trajectory. So at L5, S1, I'm going to sort of now aim for the 9 o'clock position. Picture that. And that's actually pretty good. It's a little bit on the medial side, so I'm just going to maybe about a millimeter or two. I'm going to just go a little bit lateral to that and then start aiming parallel to the superior end plate of L5. So I'm going to sort of aim caudally a bit. Picture that. So that starting point is a better starting point, but I'm going to still aim even more caudal than that. Picture that. Right, just like that. So that, as you can see, I'm actually parallel to the end plate of L5 there, so I'm going to advance this and then get a picture. Okay, so that looks pretty good. I like the trajectory of that. Picture. And I'm going to aim up just a hair. Picture that. So as you can see, I've reached the medial border of the pedicle here. So now we're going to save that, transfer that over, and then go to a lateral. So as long as I'm on the lateral view, as long as I'm past the posterior border of the vertebral body, then I'm safe. Now, if I'm anterior to the posterior vertebral body, that means that I could potentially penetrate the medial cortex of the pedicle there. So let's see what this looks like here. So that looks good. We've just penetrated the posterior vertebral line of L5. And so now what we're going to do is we're going to unscrew this. So Bassam, you can unscrew that there. This is Dr. Isaac from surgeon extraordinaire from Germany. And then he's going to put in this guide wire. So you'll feel a sort of a hard endpoint. And once you get to that endpoint, just put it in about another centimeter.
Okay,
that's perfect. Picture that. That looks great. So then now, sort of take this out by just kind of wiggling that and securing. Oh, it went advanced just a little bit, so got to be careful there.
Okay.
There we go. Perfect. Yeah. Okay, great. And then now, picture that. See how advanced a little bit? So you have to be very cautious because we're now at the anterior border of the vertebral body. So I'm going to back this up just a little bit. Picture. And this is about where I want to be. No more than about one half of the way through the vertebral body. So we can snap this down there, and I'll let you do that. And then why don't we go back to an AP again? And you can see on the lateral view, I am parallel to the superior border of the L5 end plate as well.
So I may need your help a little bit.
Yeah. Like that. Yeah.
Here we go.
Great. Yeah, great. So let's take a look at that picture. And then come up north just a little bit. And then I'll take another Jamshidi needle. Okay, great. So S1 is going to be a little bit different. And can you come down just a little bit? So we can center it right there and picture that. Okay, and picture that. So S1's just a little bit different. As I mentioned previously, instead of the 9 o'clock position on the left, you want to start a little bit more caudal. So I typically aim for like the 7 or 8 o'clock position. And so knife, please. And the other thing to be aware of, and I can feel this, I can actually feel the iliac crest here. So I gotta try to avoid that. I can tell that the iliac crest is gonna really force me medially here. So I'm gonna sort of follow the same trajectory and picture that. And that's about where I wanna be, but I wanna aim it up toward the sacral promontory. Picture that, just like that. Mallet, please. Picture. Maybe aim it up just a hair there. Picture. Picture. Okay, save that and then go to a lateral.
Hey, Jeff,
Yes.
can you sort of outline, I don't know if you can outline on the image what you use as landmarks for S1. We can see the pedicle at L5 clearly. Show us an analog there, will you?
Are you able to maybe put it onto the screen? Because he wants me to sort of draw out where. Yes. Yep.
Or just
Oh, sure.
or just point on the X-ray?
On the X-ray?
Yeah, maybe.
I'm not sure if I can. You guys can't see this obviously here.
We've got an AP of the, or an AP view at L5S1 up on the screen here. Is that on your monitor or no?
So Tyler's going to try to jerry-rig this thing. Can you switch to camera 201?
I'll say also this.
There we go. Yeah.
Yeah.
But it's upside down though, Tyler.
Whoops. Yeah. So this looks like this guy has this cadaver has bilateral sacralization of L5 as well. Do you agree?
Yes. So this patient absolutely has a transitional vertebra and sacralized L5 vertebra. So which picture are you guys looking at here?
We've got an AP pelvis right now, and I don't know if it's live. It may be.
There we go. No, Tyler's doing it.
Yeah.
Perfect. Okay.
You are.
So if
You're
you zoom into this picture here, that'd be great. So what we're looking at here's L5 pedicle on the left. We started at the 9 o'clock position on that clock, and then we made it parallel as possible to the superior end plate of L5.
Right.
So S1's a little bit different. And this is a little bit, the anatomy is a little bit different also because of the fact that the patient has a transitional vertebra. But the S1 pedicle is right here.
Can we blow that up, the screen he's working on?
Can you mag that a little bit?
There, here it comes. That's what
There we go.
There we go.
So I don't know if you can see this, but
Yes.
here, this is the S1 pedicle here, the
Got
shadow
it.
of the pedicle. And we start a little bit more like on the 7 or 8 o'clock position, and then aim it towards the sacral promontory, which is right here. So this is the end plate of L5 S1. And so we start lower and then aim a little bit higher right towards there.
Good.
And so that's what this shows right here on that AP view, which is good. Okay.
Right. So you did exactly, or you showed exactly what I was asking. Thank
Yep.
you.
Okay, great. Why don't we shoot a lateral? Okay, and then can you come down south just a little bit? And picture that. Okay, so we're beyond the posterior vertebral body of S1, so we're gonna actually put a guide wire here, so that looks pretty decent. And it is heading up towards the sacral promontory, which we like.
Okay. Went 1 centimeter inside.
Yep, so that looks, and you still had a good endpoint, right?
Yeah, right.
Okay, so now you can take this out and then sort of hold it up here because it's gonna have a tendency to pull it out. Great. Okay. And then so picture that. Okay. Now we're going to start putting in some screws. And I sort of mentioned this in my talk, but I'd like to take a look at sort of how these guide wires are sort of laying relative to each other. And these are not, these are stainless steel guide wires, so they are bending just a little bit. I'm going to put in the first screw, and then Bassam's going to help me put in some of the others. So if you can hold on to this for the time being. This guide wire bent just a little bit, but essentially what I'm going to do is I'm going to go down the coaxis of the screw, and then get down sort of where I can feel that and picture that. And then, yeah, can you straighten that? Normally I use power, but we don't have power here today. Picture that. And so once the screw has gone beyond the posterior vertebral body, then I can take this out now. So I can take this out. And now what I'm going to do is I'm going to sort of feel for a little bit of resistance. And when I feel that, I know that I'm sort of bottoming out on that starting point. So picture that, that's about where I want to be. And I want to be very mindful as far as the depth at each single level. So at every single level, I want to make sure that I'm actually at the same depth. Understanding that there's lordosis, so that L1 is not going to be as deep as L3 is going to be probably the deepest, and then L5S1 is going to be more shallow again. So then now, do I just take it out?
Ratchet out.
How do I take this? Got it. Okay, great. Sorry? Yeah, here you go. So then we're going to go with the next screw, which is L2. And Sam, you can go ahead and put that one in.
Okay.
So try to go along that same coaxis. Yep, until you feel bone.
Okay.
Okay, and then picture that. Want to make sure that looks great. It's coaxis to that. The other way.
Yeah.
Yep. Give a little bit of downward pressure until you feel it capture the bone. Mm-hmm. And it's going down, which looks good. So let's see where we're at.
Okay.
So it's reached there.
Shot, please.
Yep.
Okay.
So now we can take that out the guide wire. And then, so you'll keep on advancing until you feel it sort of a little bit of resistance. You feel it?
Yeah, I would like to have a shot, please.
That looks great.
Yeah.
So I would just leave it at that. And then we want to make sure that we sort of keep these sort of parallel with each other. These, okay, now you can unratchet. Essentially what you do is I'll hold on to this, and then you just unscrew it. Yep. It's stuck.
It's stuck.
Yeah. Hold on one second.
Please hold it.
There we go. Good. Okay. Picture that. So we might want to advance that just a little bit. Do you have a free driver by chance? There you go. So just advance this one maybe about a half a centimeter.
Shot, please.
Looks great. Perfect. Okay. And then you hold on to these. I'll do 3. Another screw, please. So we go down the coaxis. You can imagine that if we had the power, this would go pretty fast, you know? Mm-hmm. But even without power, we can actually picture that. Can I see if the guide wire sort of catches a little bit, you can use cantilever bending to bring this guide wire out. Here you go. And also, I'm taking a look at sort of the depth of each one of these relative to one another, because I can see that L1 and L2, there's a little bit of a depth discrepancy. Picture that.
Right.
And so the L3, I want this one to be probably the deepest out of all of them. Picture? So I kind of want this cascading effect, not only in the sagittal plane, but as far as the depth goes too. So that actually feels pretty good. this one out.
Just to clarify, the depth there is really because of the lordosis, right? So you're
Correct.
at the apex of the lordosis. Right?
Exactly. But you also don't want so much of a discrepancy, because what can happen is that if there's too much of a discrepancy, you can actually pull out the screws, especially in the osteoporotic bone, you know? Mm-hmm. So why don't you go for L4, Sam? Okay, let's see where we're at. Picture that. See, we're bending the rod, or the screw just bit, and picture that. Picture that. Perfect right there. So this is the L4 screw that we're putting down right now. See where we're at? Okay, now you can take the guide wire out and then advance it maybe about another centimeter.
Sharp, please.
Maybe just a little bit more. That should be good. Yep, perfect. So you hold on to this while you unscrew that. You gotta hold on to it. There we go. Perfect. Okay, great. So now it should be actually, the depth should be a little bit more superficial. You're almost out. Keep on going. There we go. Okay. And then hold on to this. Why don't you put this one in L5?
Yeah.
And I'll hold these for you, because S1's just gonna be a little bit different.
Yeah.
And you can see that L5 is really starting to go from cranial to caudal there. Let's see where we're at. Okay, change your angulation a bit. Perfect. Try that. So I can tell 4-5 is gonna be a little bit challenging because the screw heads are so close to each other. When we advance a rod, it can be, if they're off on that sagittal plane, it can be very challenging to get it from the 4 to the 5 screw head. To that? Okay, so we're probably gonna need a little bit of downward pressure on this. So I can tell it might be kind of sclerotic. Picture? There we go. I think it's just capturing now. Picture? Okay, go ahead. X-ray? Okay, now we can take this out. Can I see the needle driver? There we go, you got it. Okay. Try to get it to the same depth as the 4, or similar depth. Maybe about another centimeter and a half. So that's maybe just a couple more turns. That should be good right there.
Sharp,
Picture?
please.
That looks great.
So the lessons you're giving, I'm going to just say it's very similar in open deformity surgery. I think getting the screws in kind of symmetric starting points and orientations is really a critical aspect of getting the rod reduced and avoiding failing a screw.
Yes.
In a very similar fashion. So same lesson in a different setting.
Yes, and this is the longer screw, right? So we're gonna try to do a bicortical screw here. All the screws that we use were 45 millimeters in length. This one's actually 50. And typically at S1, we typically tend to use a shorter screw, but this one, since we're gonna do a bicortical, picture that. Picture. Okay, can I see the, yeah. So I'm keeping a very close eye on the tip. Picture that. And I just felt give again. So I'm feeling some resistance right there. So we're gonna double check to see whether or not this is actually a bicortical screw. So save that, transfer that over, and then go to an AP first. I think we can take this handle off too, right? Okay, so we can take a look at that there. Yep. Come up north. Yeah, actually, so we have to straighten that out a bit. Come up north just a little bit. Yep. And then picture that. and then change the rotation. So you want to rotate it kind of counterclockwise. And you can see these screws, the trajectory of these screws are much more lateral to medial. So, early on, if a lot of radiologists aren't used to seeing the trajectory of like MIS placed screws, they almost look like they're going too medial. But in reality, this is sort of the plane that the pedicles are normally at. So save that and transfer that over. So this is an AP view. Now we're going to do what's called the reverse Ferguson view, or the pelvic inlet view, and this will give us almost an axial CT cut of S1. So go ahead and picture that.
Nice.
So do you guys see sort of the tip of that?
Yeah.
Is at the anterior border of the sacrum. And so I'm about maybe like one thread into it. So actually we can go just a little bit deeper. And as I told you before, I could actually feel that it was actually much better bite. Picture. Maybe just a little bit more. You got to make sure you don't plunge here for obvious reasons. Picture. And that's a really great bite. This is really nice and solid right there, you know? So we're done with that. And then why don't we then go to a lateral view? So we're going to take this out. Actually, I'm going to back it up just a hair just because of the fact that I don't feel it moving too much, meaning that we really want this to be like multi-axial. Oh, this is really stuck in there. Sorry? Or do you have like something to hold this? Yeah. There we go. So Zach was giving me counter torque there and allowed me to make that freeze. So this is the last step and oftentimes the most technically challenging. And I'm not gonna lie to you, this may be a cluster. So please have a little bit of patience. Here's the rod. So we've taken a rod and we've sort of guesstimated the length of this just based on how it's sort of lying on the skin itself. So this is what the rod looks like. And so the other thing you can sort of do is, again, take a look at how these screw tabs lie in skin and sort of get a general estimate. But this is essentially the lordosis that I want. So number one, I want to maximize my chances of actually getting it into each one of these screw heads. So essentially what I'm doing is I'm going to go into L1 percutaneously through this first incision, go onto the very bottom of that tulip, and then bring my hand down, and then guide this through each one of the sequential screw heads. It's not easy, but luckily this patient doesn't have scoliosis, so this should be a lot easier than scoliosis, a typical scoliosis case. But what I'm doing here is I'm actually going down, and I feel that, the metal, which is the bottom of that, I'm gonna bring my hand down. And what I've done already is I've actually done a little fasciotomy back here so that it'll allow this back part of this rod holder to sit down once we're all done. So what I'm gonna do is I'm looking down, and can we turn on the lights here a little bit? So what I'm doing is I'm looking down at each one of these screw heads, and I'm using this as a guide because I can actually control the direction as well as the depth of this. So the depth I can control by going cranial caudal. The direction I can control by rotating this medially and then laterally. So I can see I'm already through L2. I'm going to try to go through L3, and this is how I can sort of tell where I am. If I turn it one way and it turns the rod, or it forces the next screw head to move, but I turn it the other way and it doesn't, that means that I'm actually too medial. So what I'm going to do is I'm going to back it up a little bit, and I feel a little give there. There we go. So I'm down to L3. So what I'm doing now is that I'm sort of seeing where these trajectories are. Can you hold this one back just a little bit like that? Of course. Great. There we go. 4. It's like kicking a field goal, you know, you got to try to like get it through the uprights. Okay, now we're on here. So now I know S1 comes up this way, so I have to actually bring my hand back a little bit so I can allow it to sort of make that turn. And we want to make sure that we maximize my chance of going in there by holding it right there. So I know I'm close because I'm hitting it. And I'm probably, if I turn this way, I may be needing to go a little bit more medial. There we go. So now that's through. Now what I do is actually, I want to come in through this blade, the first L1 blade, push this up, and then bring it out, and then just seat it this way. And then picture that. Okay, and picture that. And picture that. Okay, so what we're going to do now is we're going to try to sequentially get these down. And this can be a little tricky. And so what we're going to do is see if we can capture one of these. Picture that. And can I get a set screw? Let's see if we can actually just lock down L5, at least provisionally. And can you hold these, or hold it together just like that, or pinch it together like this? Yep. Yeah. So hold just like that. Picture that. Picture. Picture. Okay, we've captured it right there. Picture. And that'll help sort of push down the other ones too. Picture. Picture.
Do you have limits on kind of how much reduction force as you put that locking nut in you're able to tolerate or willing to tolerate?
Give me another one. You know, I try to get a good feel. I'm not going to try to kill this.
Right.
So what I'm trying to do, and I'm also keeping an eye on the lateral view because I want to make sure that the screw isn't actually coming up while I'm doing this.
Sure.
So essentially, what I'm doing is I'm just sequentially using the power of these reduction screws.
Right.
Picture.
I also noticed you didn't do an AP view. Would you typically do that
at the end?
Oh, you do it at the end.
Yep.
So you're confident enough passing the rod that you've got it in every screw.
Yeah, because I can actually see at every single level that the rod's actually through the tulip head.
You're actually looking down the tulip head and seeing it.
Mm-hmm. Picture that.
Got it.
See how it's reducing, the rod is like now sort of reducing. Picture. Mm-hmm. And this is also a very powerful technique to use for spondylolisthesis. So say, for instance, the patient had an L5 S1 spondy. I would lock down S1, and then I would sort of calculate how much reduction I'm going to need based on the distance between the rod and the bottom of the screw head. And then as I reduce this down, then the L5 vertebral body actually comes up to that rod. Picture that. Yeah, so this is reducing nicely. Okay, picture that. Okay, and Bassam, why don't you do the L4? And I'll hold these two together for you here. This one right there. Mm-hmm. Go ahead and put a little bit of downward pressure. Do you feel like it's catching? Oh, it sounds like it. Picture? Great. Okay, keep on going. Okay. Picture that?
Yeah.
Okay, good. Okay, you can take that out. And then if you do L3, that should even help reduce L4 even more too. So essentially, we're kind of sequentially bringing the rod down. But in reality, you know, if we did inner body work and we sort of did the releases, what's really happening is that we're actually bringing the scoliotic spine up to this rod and reducing it, just like the whole spondylolisthesis, how we do the reductions. Capture? Picture? Watch your elbow?
Yeah.
Yep, good. Good. That's good there, yep. Come up north just a little bit. And then let's do L2. And in reality, I'm not really happy with the direction of these screw heads because it's sort of doing this zigzag pattern that I sort of talked about earlier. So we should have done a better job of actually placing the screws so that it's within the same sort of sagittal plane. Picture that. Is it capturing?
Yeah.
Good. Yeah, this one should be reducing pretty easily. Okay, let's see where we're at. Picture. Okay, and then you can take that out. And then one last one here. This patient had a Greenfield filter.
Yeah, I see that.
Yeah, right.
We're not going to blame you for that.
Please don't, Bob. And this one should go in pretty easily, you know? And at the very end, then we'll do the final tightening, and then we'll take out the rod holder. Picture that. Pretty good. Okay. And then the final tightener, I want you to start from the bottom and come on up. And I'm going to sort of act as your counter torque and then hold these together while you do it. It should be, yep.
No.
Yep. Great. And just sequentially keep on coming up and do L5. Stay within that coaxis.
So do you do inner bodies at every level?
I try to.
So even if you're going into the thoracic spine, you'll do like an X-lift at 10, 11, or higher?
I like to do it at the apex of the curve, and it's very similar to the growing rod, you know, right? Where you're fusing at the apex of the curves. Mm-hmm. So I try to get at least 3 or 4, if not 5, inner body levels at the apex of the curves. In between, in the transitional levels where it's relatively straight, I don't. And at those levels, I'll just do like a facet fusion.
Okay.
And as I mentioned, the only other level is L5S1, and typically I'll do a T-lift, you know?
Right. And when you say a facet fusion, you're doing that down the tube, yeah.
Yep. So essentially, if I was going to do a T10, T11 facet fusion, I would just follow down the guide wire of T11, and that'll lead me right to the facet joint of T10, 11.
Mm-hmm. And where you've done inner bodies, you don't do any necessarily any decompressive work, and you don't do any posterior fusion work. Is that right?
What was the first part of the question?
So at the levels you've done inner bodies, leaving out 5-1, let's say, you don't do any decompressive work, and you don't do any posterior fusion work.
Oh, I do, absolutely. Like I will still do decompressions where the patient's most symptomatic. So say, for instance, they had stenosis. Oh, let's get an AP. If they have stenosis in the foramen or lateral recess, I'll actually go down there and do the decompression. So that's why I like to do the T-lift at the concavity of the lumbosacral curve at L5S1. And then also, if the patient has like lateral recess or foraminal stenosis at the concavity of their major curve, and I feel like it's too bony and that the indirect decompression from doing the inner body work is insufficient, I'll go in there and do a decompression. Okay, that looks good. And then can you come down south? Show me the very bottom. And then can you cant it towards the, oh yeah, because this is in the way, right? Okay, go ahead and picture that. It's gonna be a little bit, the rod was a little bit longer than I'd probably like, but that looks good. And so then you can unscrew that and then take the rod out. And then essentially, the final step would be we'd go in there and then break off the tabs, and then we would just close the wound.
Right, right. Well, you made that look very easy. I've done these for trauma and for infection in some cases, and I can't remember one that's gone as nicely as yours just did. So congratulations on that.